I will just pop over to Facebook. To make sure people see us. There we are. Okay. I always love to see people waiting for the 12 o'clock hour to roll over, and they're already jumping in the room, so we don't want to keep them waiting, do we? Let's start the show. Hello, everyone, and welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this month and every month. And my background is I'm a writer and a filmmaker, and I've been working with CCF for over 10 years now, creating all kinds of video content, live video series and conversations like the one you'll watch today, patient-centric documentaries, training videos, conference videos, short-form videos, long-form videos, but all with the same mission in mind, and that is to spread awareness and education about neuroendocrine tumors. That is what we are here to do. Now, the value that I see very clearly in this show, which we've been doing for, I think, almost 3 years at this point, is twofold. One, the information that you will get from our guest today, our expert, as it were, and two, the shared stories and shared experiences from within the community itself. That means the overall net community and the smaller community here in the comments section of Luncheon with the Experts. You can see people signing on, saying where they're from. Hello from Baghdad. That is the first time, Wasim. Welcome. So if you are new to the show, and new to this space, I want to welcome you as well and encourage you to do the same as you see people in the comments thread. Introduce yourself, reach out to them, embrace you. I can promise you they will embrace you back. This is a very strong, very supportive community, and I feel very fortunate to be a part of it, even just from kind of a tangential outside perspective. A couple announcements before we get started. First, we always want to thank Ipsen Biopharmaceuticals for their support of Luncheon with the Expert series. We couldn't do the show without them. And we also have this disclaimer from them that we like to say at the top of the program. That is, that the opinions expressed by the guest presenter today, as well as the questions asked by you all, the audience at home, have not been created or suggested ahead of time by the sponsors of Luncheon with the Experts. And CCF doesn't promote or endorse any of the views, opinions, or information provided in the presentation. So, audience members should not rely solely on that information and those opinions expressed by the guest, and should seek guidance and direction from their own medical advisors, their own team, regarding any choices they make about their health or treatment. So that last line is really the takeaway. We're going to give you some good general advice, hopefully answer some of your questions. But each case of this disease is unique. That is one thing that I'm not a medical expert, but that is one thing I've definitely learned in 10 years of working with CCF. So each plan and path forward is unique as well. So it's really important that you discuss this with your home team. And another announcement that we're really excited about, which has happened recently, and CCF has partnered with LACNets, which has been a long time coming. We're very excited about that, to provide a support line for those affected by NETs. And that support line provides guidance, resources, referrals to NET patients or their loved ones. And so this partnership formalizes LACNet's support line, which will now provide support to those contacting CCF in addition to their direct inquiry. So if you message us, you are now messaging that joint effort, the support line from LACNet. So we're really excited about that. Okay, let's get to the good stuff. Let's get to the guest today, who is I consider a friend now. You've been on the show a few times. Dr. Thor Halfdanarson. How are you, Dr. Halfdanarson?
I am well, thank you.
Yeah, it's good to have you back. I know that people are excited. I've seen some of the comments when we were posting the announcement graphics earlier this week. A lot of people really respond to the way that you do the work that you do, and you have quite a reputation. So we're always happy to have you here on the show. For those who aren't aware of that reputation, tell us a little bit about who you are, what you do, where you work. But the way I like to phrase it is the role that you fill in this neuroendocrine tumor community that I've alluded to.
Sure. I'm a medical oncologist. So originally from Iceland, I've been in the U.S. for 23 years almost, and actually in 2 weeks I've been here 23 years, and so did my residency training at the University of Iowa, where I got initially interested in neuroendocrine tumors. Did my oncology training at Mayo Clinic from 2003 to 2007, and I went back to the University of Iowa for 5 years, and then I've been since 2012 at the Mayo, initially in Arizona, and then since 2015 at Mayo in Rochester. So I see almost entirely patients with neuroendocrine tumors, although I do see a little bit of other malignancies as well. And very interested in advancing the field, sort of moving the field forward with neuroendocrine tumor management, and working with patients, activating clinical trials and things of that nature. So that's really what I do most of my time. I think the neuroendocrine tumor part of my brain is pretty much always switched on.
Copy that. Understood. I think the people that do know your reputation are already responding because our numbers are kind of shooting up high. So that's always a good sign this early in the show. That means people were anticipating this, and that makes me very happy. Couple of things I want to welcome. The thing about the show this year that's different is we are simultaneously broadcasting to YouTube, Facebook, and Twitter. Facebook is still definitely our primary audience and largest audience, but that brings in a few new faces, which is nice, including Dixie Ann from Trinidad. Welcome, Dixie Ann. And listen, folks, I don't want to play favorites, but to Patty, to Jerry, and to Annie from North Carolina, I just want to say a special hello because I am also in North Carolina. Annie, I think this might be the first time you are here, so welcome to the show. I'm right in Durham, so not far from you in Raleigh. Folks, a couple of best practices to let you know how the show is going to go down. We get a lot of questions. We try our best to get to every one of them. Unfortunately, we fail every week or every month because we get so many questions, but that actually keeps the show going. I want to try to get to your question. I will try everything I can. The way to make that easier for me is to think about it in little general chunks, right? We can't answer very dense, very case specific questions in this format. Often our guests are welcome to anyone emailing them, or you can certainly follow up with us directly, and we'll in the support line that I discussed earlier. But it's really hard in this format when Dr. Halfdanarson probably doesn't know your specific case to get really, really down to the nitty gritty. So try to ask in general terms, and we'll try to answer as best we can. If you're still in the call, we might ask you for clarification. And we're just going to try to give you good guidance along this journey, good answers to your questions. You have no limit on the questions you can ask. So if you have follow-up questions too, please ask them. If I haven't seen it, you can ask it again because we do get a lot. So hopefully that helps you and helps me do my job better, which is, of course, to serve you. So let's go ahead and start since we have so many great numbers. We're about to break 100 already. That's lovely to see. From Robert. Simple question, but probably not super simple answer. Robert says, can PRRT be curative?
Yeah, that's a great question. So we don't think of it as a curative treatment. And the reason for it is that when we do PRRT, so essentially delivering small particles of radiation directly to the tumor, we're probably never going to hit every single cancer cell in the body. But we do rarely see what is called a complete radiographic response. That is that all of the lesions have disappeared from the scan. It's probably less than 2 to 3% of the patients, and we don't know how long that may last. So I will say that I don't think of PRT as curative, but it will be interesting to see long-term follow-up. Let's say after we've been doing PRT for a decade or two, are there patients who got PRT whose neuron tumors never came back? So right now, I don't think of it as curative. Is that really the truth? I just don't know.
Got it. Well, thanks, Robert. I appreciate your question. Here's a question. This is a little lengthy, but I'm interested in. Let's see if we can take it. Steven says, oligometastatic cancer is a new term? Question mark. I am a 7-year survivor of a resected carcinoid in the ileum with metastasis to 4 lymph nodes. The liver might be its next stop. There's so much new technology and science, such as the gallium-68 and new radiation treatment options. How does the term oligometastatic cancer apply to carcinoid cancer metastasis? What do we know about carcinoid metastasis cell biology? Is it just playing whack-a-mole, seek and destroy, or is playing whack-a-mole, seek and destroy better than treatment to slow new metastasis?
So yeah, so that's a great question. And just as for the oligometastatic, so oligo, if I remember right, means a few in Greek, and so versus poly, which means many.
Hmm.
So oligometastatic means just few metastases. Then the question is, how few are few? Less than
Right.
five, less than 10. We there's not really a good explanation there. So let me just give a little bit of a background. So if you have someone with small bowel neuroendocrine tumor and with liver metastases, if you remove a chunk of the liver that looks normal and you look at it really, really carefully in the microscope, you will find tiny little clusters and islands of neuroendocrine tumor cells sort of scattered throughout a seemingly normal liver. So we think, at least with the small bowel neuroendocrine tumors, that most patients with liver metastases actually have it widespread in the liver. But that said, some of those lesions never grow to become anything. And there was a study from either Denmark or Norway that looked at patients like that. And in 60% of cases, I recall, the tumors never grew, and even over a number of years. But that said, there are probably truly oligometastatic cases out there where we have just two or three or four metastases. And we are now starting to pay more attention to them, and we're actually starting to go after them surgically. So, for an example, as an example, I just saw someone recently who had what seems to be oligometastatic lymph nodes after surgery that was done a few years ago. And the surgeons looked at this and they said, "We can actually get this, and we feel it's a reasonable thing to do." We have started sort of doing more ablation and focused or targeted radiation treatment, including in patients who have many metastases, but only a few of them are growing. And now we're starting to sort of sometimes consider radiation or ablation, where we stick a needle into the tumor and we burn it or we freeze it. And we see that there are multiple tumors in the liver, but maybe only two or three of them are growing. Then we can maybe pick those out, keep doing what we're doing with octreotide or lanreotide, and maybe get some more mileage on that specific drug. So maybe the patient, instead of switching to something different, maybe with more side effects, we can get another year or two by doing that. So the whole concept of oligometastatic neuroendocrine tumor is definitely evolving. I think it exists. It's probably not very common, and if we can go after it, and if it's reasonable and relatively low risk, we probably should. Hopefully that answers that.
Got it. Yeah. Thanks, Stephen, for your question. And if you have a follow up question, or if it didn't answer your question, please chime back in. So this is a comment, not a question, but from Lynn. Lynn says, just left visit with a net surgeon and oncologist. Nearing 5 years into this journey, we got good news. So my comment to everyone is to have hope and faith. There is success. I think it's important that we share those comments as well. And back to my point about the community here, this is a big part of that. So thanks for sharing that, Lynn, and that's great news. We're all happy to hear that. Next question comes from Bridget. Bridget says, my last endo showed the lining of my stomach has changed. What does that mean? Did you follow that?
Yeah. So let me. So is that? Let me see if I can find the. Okay. So the lining, yeah. So that's actually where we need the. So was that on seen on imaging, or yeah?
Her
So
last endo.
yeah. Okay. So let me see if I can find. So the lining of the stomach has changed, and
Yeah, and what does
so
that mean?
scrolling down to see if I can. Did you get that? Did that question come through? Yeah.
Here, well, I can show it. Let's see.
Yeah. So the last endo showed the lining of the stomach. So it's hard. So this and so again, we need a little bit of a background. If we know that certain neuroendocrine tumors can change the lining of the stomach, especially the gastrinomas. The hormone, the neuroendocrine tumors that produce this hormone called gastrin that can cause some thickening of the lining of the stomach. But there can also be some other reasons for that. Let's say if someone has gastritis, which is inflammation of the stomach, or it could be a neuroendocrine tumor involvement of the stomach lining. And typically, when we see this, I rely on the gastroenterologist to tell me, is this something to be worried about? And if so, can you just biopsy this for me and just let me know what's there.
Yeah, got it. Thanks, Bridget. Appreciate you. Next question from Joe. Joe says, "Do you think a 1.4 centimeter thyroid node should be watched or biopsied?"
That actually is a great question. So, as all of these questions are, so we are picking up a lot of thyroid nodules on gallium 68 or copper 64 dotatate imaging. And most of them are what's called the benign thyroid nodules that don't need any specific treatment, but some of them are actually early thyroid cancers. So thyroid cancer is very common and probably much more common than neuroendocrine tumors, although I'm not a thyroid cancer expert. And so if you have a 1.4 centimeter nodule in the thyroid, the next step would be to do a thyroid ultrasound, a focused thyroid ultrasound. That can tell us with some certainty if it's like a suspicious thyroid nodule or if it's something totally harmless like a cyst. If it lights up on the PET scan, it could be a totally benign thyroid nodule or it could be an early thyroid cancer. So if the ultrasound shows that the thyroid nodule looks suspicious, we follow that with a thyroid biopsy, which is very, very easy to do, very, very safe. And that'll tell us what is there. One of our trainees here, and a fellow here who was in endocrinology, looked at this at Mayo, and he found that of all of these thyroid nodules we found on the PET scans, a tiny fraction of them were cancers. So most of them are totally harmless. But we won't know until we do an ultrasound and possibly a biopsy.
Got it. Thank you. Moving on, next question comes from Stacy. Stacy says, "Should a less than 1 centimeter net on the head of the pancreas be removed?"
That is a really excellent question. Like I said, so and this is something that's being debated hotly now.
Hmm.
So there are now two studies, including one study that looked at 400 patients from Italy, and mostly from I think mostly from Italy, or some may have been from Germany too. And so they looked at 400 patients with small grade 1 or grade 2 neuroendocrine tumors of the pancreas that were less than 2 centimeters. And 400 out of these 500 had observation where they just sat and watched them with scans. And most of them didn't really move over the next 2 or 3 years. So we know that at least in the short term, you can actually watch these with scans, and you may never have to do anything. And we don't really understand why is it that you have a tumor in the pancreas that is malignant and is small but just doesn't grow. So now we're increasingly, and I'd say almost always recommending that we watch these tumors. But there's one very important exception to this. If this is a functional tumor making like insulin or some other hormone causing symptoms, it probably needs to come out. Same thing if we stick a needle in it and it's a higher grade, a grade 3 neuroendocrine tumor or a grade 3 neuroendocrine carcinoma or some other tumor, it probably has to come out too.
Got it. Thank you, Joe. Stacy, appreciate your question. Next question comes from Grace, who says, "Hello from Kenya." Hello, Grace. Glad you're here. If one takes PRRT after a progression on octreotide, is it possible to revert back to octreotide after a progression on PRRT, or is that octreotide bridge closed permanently?
So that's such a good question, and we don't really know the answer to that. So one of the most sort of practical important questions right now with octreotide after PRRT is the question: should we continue octreotide or lanreotide after PRRT? And those studies have actually never been done. So there was one study from Germany that said if you continue octreotide or lanreotide after PRRT, you're going to get much more mileage out of the PRRT. But it wasn't a randomized study, and the patients were probably not identical in the two different groups. So we don't really know. So in certain situations, let's say if you had PRRT and you did not continue octreotide or lanreotide after the PRRT, and now there's tumor growth, maybe a year or two later, it actually would be perfectly reasonable to go back on octreotide and watch very carefully. You're probably not going to get very far without tumor growth, but you might. So the question, it's a yes. There is probably a role going back.
Got it. Thank you. And thanks, Grace. Glad to see you here. Folks, if you just joined us or joined us a little bit late, this is Luncheon with the Experts, a Carcinoid Cancer Foundation program. We're here with Dr. Thor Halfdanarson. Great questions so far, as Dr. Halfdanarson has said, and lots of people in attendance. So this show is going great so far. Let's keep it going. Next question comes from Bridget. Could stomach nets metastasize to the ovaries?
That's so they probably can if they grow large enough. And actually, I think I have seen an example of that. Yes, so most stomach nets are what's called type 1 stomach nets, and they are small, typically less than 1 centimeter. And most of the time, we just go down there with an endoscopy every so often. You just pluck out those that are growing, and you never have to do anything. So I tell some of my patients that the vast majority of the stomach nets are nuisance in the sense that you have to continue to watch them with endoscopy, but they never really go anywhere. But there is a smaller minority of stomach nets called grade 2 and especially grade 3, and they can actually go places. And I could easily see how they might go to the ovaries.
Got it. Thanks, Bridget. Hope that helps. From Annie, colorectal surgery for the first net in February of this year. Stage 4 net has metastasized to the T11. I'm being infused with lanreotide monthly and Exgiva quarterly, scheduled resection for this October. Is this typical?
That's, I think, a fairly typical approach. So I know that most patients diagnosed with cancer would really want the cancer to come out as quickly as possible. But with the lower grade neuroendocrine tumors, you can wait, and it's not unreasonable to go on octreotide or lanreotide for a few months, sort of see how this behaves, and if it's really truly not growing, then go after it. So one of the reasons for waiting is that what if now 2 or 3 or 4 months later you have a lot of new lesions that have popped up? Then surgery might not be as feasible or even as appropriate. As for the Exgiva, so for a solitary asymptomatic spine metastasis, I probably wouldn't do it. And but that said, it's not wrong. So we and just stay tuned. Mayo is publishing probably the largest study on bone metastases and neuron tumors in general. It's coming out in the next few weeks, hopefully, or next few
Okay.
months. So I can't really tell you much because it hasn't been accepted yet. And but we're actually finding that bone metastases are probably more common than we thought, and actually more likely to cause problems than we thought. So if they are solitary or few of them and causing pain, we can radiate them. If there are many of them, then Exgiva or Zometa are reasonable things to do. But this all sounds very, very reasonable.
Okay. All right. Thanks, Annie. Appreciate your question and glad to see you here. Next question from Lori. What role do molecular biomarkers play in treating net cancer?
Yeah, that's another outstanding question, and then really that field is really evolving. So, and when you talk about molecular biomarkers, it's we can sort of break it down to sort of three main types. So one of them would be to take a piece of the tumor and test the tumor for molecular alterations like mutations or gene fusions. Another one is to check the your own genes, do what's called germline testing, do like a saliva test or a blood test to look to see if these are mutations you were born with that predispose you to having neuroendocrine tumors. And the third one, which is using molecular tests such as the NET test to follow or look for recurrence after surgery. So these are all molecular tests, but they're all like different tests. So the answer to this, if I try to keep it simple, is that for the lower grade tumors, grade 1 and grade 2, and possibly well differentiated grade 3, molecular testing typically doesn't add much. For the high grade tumors, the neuroendocrine carcinomas, it may. And today, actually, earlier this morning, I saw a person with a neuroendocrine carcinoma who has molecular alterations that are strongly predictive of later response to immunotherapy. So definitely do that. And we just had a patient recently, and we'll hopefully soon have a publication where a patient with a neuroendocrine carcinoma had what's called HER2 expression, which is something we see in breast cancer. And we treated that person with HER2-directed therapy, and it worked. So definitely use this in select patients. As for the germline testing, yes, if you have pancreatic neuron tumors, and especially if you're younger than 50, you should probably have germline testing to look for MEN1 or similar conditions. The NET test to follow up with using molecular testing to follow up after surgery is something that we're increasingly using as well. So a lot of things are happening in molecular testing, and more tests are coming.
Good to hear. Thanks, Lori. Appreciate your question. Next question from Stephanie. Do lanreotide and octreotide injections control your serotonin, gastrin, pancreastatin, and 5-HIAA levels? And the question is, if you stop these injections, will the levels go up again?
Yeah, that's a really good question. So if you have small bowel neuron tumor with what's called carcinoid syndrome, that's the production of serotonin, and the serotonin will then get metabolized or changed to 5-HIAA. So serotonin and 5-HIAA are almost like two sides of the same coin. And if you stop the treatment, that will probably start producing the tumors will start producing more of it again. So in patients with carcinoid syndrome, we almost never stop the octreotides or the lanreotide because we want to keep the syndrome under control. What is if you have a pancreatic neuron tumor that is producing hormones, we are actually now starting to understand they can actually stop hormone production on their own. And we don't really know why that happens. But for functional tumors that produce chemicals or hormones, we keep the lanreotide or the octreotide, and if you stop it, most of the time the symptoms will come back.
Got it. Thank you. Next question from Tom. After 6 years on, almost 6 years on lanreotide, the injection is getting more and more painful. Do you have any suggestions for this? What does it mean? Anything in particular?
No, so this is something we're starting to pay a little more attention to, and why this is, I just don't know. I'm not sure if warming it changes much. Sometimes, if the injections are getting more painful, then switching to octreotide. So there was a study from Memorial in New York that looked at pain with octreotide versus lanreotide, and I don't recall all the details, but I seem to remember that there was really no difference in the pain. But sometimes, yes, because one goes under the skin, one into the muscle, sometimes you can switch from one or the other. But if you do octreotide or sandostatin, you just need to make sure it actually gets injected into the muscle, because if you inject it under the skin, it's not going to work as well. And a couple of really exciting things on the horizon. So there is a clinical trial looking at self-administered long-acting octreotide injected under the skin. So that study is ongoing. It's called the Sorrento, and so that is it's not yet ready for use, but that is a small volume injection, doesn't leave the same lumps as the others do. And if that works, that might be a great option, but we won't know for probably another 2 to 3 years if that's a good option. The other equally exciting option would be the oral somatostatin analog drugs. And there's now a trial looking at a drug called paltusotine that is an oral drug that is supposedly should work similar to octreotide or lanreotide. And that would eliminate, if that works, might actually eliminate the shot. So if you have an opportunity to participate in a trial like that, and there are some others I may not be aware of, by all means do. This is really the only way we can move this field forward. It's for patients participating in clinical trials.
Got it. Thank you. Appreciate that. Folks, we are just about halfway done, so plenty of more time and plenty of more questions to get to. Let's keep it moving. Sean says, when diagnosing thoracic malignancies, are there particular stains you use to identify the type? Is it obvious? And is there a risk of spreading when subcarinal and mediastinal lymph nodes are removed? Oh.
Great question. And actually, I gave a talk on this yesterday.
Okay.
So the lung neuroendocrine tumors come in really 4 different flavors. So the ones that I think we're referring to here would be the well-differentiated neuroendocrine tumors of the lung, also called lung carcinoid tumors. This is actually the place where the term carcinoid tumor is still alive and well, and as a diagnostic entity. So about probably 8 out of 10 lung carcinoid tumors are what's called typical carcinoids, very slow growing. And if you remove them and you remove the lymph nodes, then the chances of, and the lymph nodes are involved, there's probably about 10% chance of them coming back in the next 10 years. And a lot of people are cured. If you have what's called atypical carcinoid tumor, which is a slightly more aggressive tumor, then the chances of them coming back in the next 5 or 10 years is probably about 30 to 40%. So the lymph nodes absolutely increase the risk of the tumors coming back. But that said, a lot of people with lymph node positive carcinoid tumors of the lung, atypical or typical, are cured after surgery. The one I didn't mention are the small cell and large cell neuroendocrine carcinomas of the lung. Those tend to be much more aggressive.
Got it. Thank you. From Jane, is alpha PRRT showing less side effects? And if so, what are the trials showing?
Well, that is if I only knew. So this is obviously a really important question. So the if you look at the alpha particle treatment, so we don't really have a lot of data there. The largest study, to my knowledge, is a study from India, reported either late last year or early this year, using actinium-225 dotatate in patients with neuroendocrine tumors, and that one showed that the treatment is definitely effective. It's most effective for patients who have never had PRRT or had a regular PRRT with Lutathera and had a response. It's not as effective if you go into the alpha particle therapy with tumors growing on regular PRRT. As for the question itself with the toxicity, so the alpha particle radiation travels much, much shorter than the beta radiation with Lutathera, and theoretically less toxic, but that's all theoretical. So we're talking less than 200 patients treated and reported worldwide. The first large study is actually already started. So this is a Race Bio Action 1. We're looking at the actinium-225, and other studies are coming. So we don't know the answer to the toxicity or side effect question yet, but we will in the next few years when we get the results of those large studies.
Got it. Thank you. Thanks, Jane. Here's a follow-up question. Joe earlier asked about the 1.4 centimeter thyroid node, if you recall. She had a follow-up question. The ultrasound showed ill-defined hypoechoic, taller than wider, irregular nodule with microcalcifications. The doc just wants to watch. Would you agree?
So that's the thyroid nodule. Yeah, I would defer to a thyroid specialist.
Okay.
So because this is, that's a little bit outside of my comfort zone.
All right.
I
Thanks,
used to
Joe.
treat thyroid cancer, but haven't done that in years.
Okay, understood. Michael says results from Y90, TACE, and bland embolization are about the same. True or false?
Yeah, so true. So we don't have high quality data. There are no studies that conclusively show that radioembolization is better than bland embolization. So there are slightly different toxicities, maybe less pain with radioembolization than with bland embolization. There are also some concerns in some patients of higher liver toxicity for after radioembolization. So there is a huge institutional variability, and we at Mayo rarely use radioembolization. Most patients we embolize are expected to have long survival, and oftentimes many, many, many years. And we're trying to cause as little liver damage as possibly. And so we cannot. We typically do not recommend radioembolization. So that said, but there are situations where radioembolization is very appropriate, but not been shown to be better.
Got it. Here's a good kind of general question I think is good for us to address. Jim says the questions and responses have been about a lot about PRRT, and the question is, what's the difference in alpha or variations of alpha PRRT? So can we discuss that briefly?
Yeah, so the difference between alpha and beta. So the beta radiation is the conventional Lutathera or lutetium 177, or back in the day yttrium 90 PRRT, which we used to do a lot of.
Hmm.
And so the alpha particles, the radiation has a much a higher energy, but it doesn't travel nearly as far. So probably the best way to explain this is that both alpha and beta cause damage to the DNA in the tumor cells. And keep in mind, the DNA is like double-stranded helix of genetic material.
Hmm.
And so the beta radiation is thought to cause what's called single-stranded DNA damage. So it breaks one of the DNA strands, resulting in tumor death or tumor kill that way. So the alpha, when the alpha particle is much heavier, much more energy, but doesn't travel very fast. But when it hits the DNA strand, it totally shatters it and causes a double-stranded DNA. And as someone explained to me, it's it's in terms of the damage done, and I'm not sure if it's good analogy, but I like it. Is that the beta is like having a golf ball come through your like front side window, and the alpha is like having a pickup truck come through,
Hmm.
and so much more damage. But whether that results in longer duration of disease control and less toxicity really remains to be seen.
Hmm.
Great question, though.
Yeah. Yeah. Thanks for that, Jim. Appreciate you. Question from Liz. What do you think about a breast fibroadenoma that was discovered on DOTA 68 PET? My breast surgeon says nothing to worry about because fibroadenoma are not a cancer.
So that's such an interesting question. So this is what happens when you get a new scan. So when we started doing gallium 68, the DOTA PET CTs at Mayo in 2016, we started picking up all of these other tumors and not tumors. So we pick up breast fibroadenomas, uterine fibroids,
Mm.
benign prostate enlargement in men, arthritis in the spine, and a whole host of other things. So the dotatate or gallium scans or copper scans are not that specific for tumors. So I would defer to the breast surgeon. So they deal with breast tumors or breast abnormalities all the time. And if the biopsy did not show cancer, I think it's totally reasonable just to watch it. So I will say we'll say this: not everything that lights up on a net PET scan is a net,
Understood.
and
Okay.
we keep adding to the list of things that may light up, but they have typically light up faintly.
Okay. Well, thanks for your question, Liz. Hopefully that helps. And let me know if you have another question. From Michael, is oral octreotide an option for treatment versus a monthly injection?
It's not yet. So those studies are ongoing. So there is an oral octreotide that is being tested.
Thought so.
I don't. I haven't seen any results, so I'm really keeping an eye on that.
Okay.
Then there are these other drugs, such as paltusotine, which is this almost like a targeted drug that targets the somatostatin receptors, but works in a different way than octreotide. So that drug is actually being actively studied now. So I think in the next 2 to 3 years we'll know more. But right now, only in trials.
All right. Well, thanks for your question. Let's keep moving forward. Gene says, I have T1D and carcinoid syndrome. Random times of insulin resistance or sensitivity are very difficult for me. Is there or are there any medications or treatments that could help?
So here I need a little bit more information.
Mhm.
So insulin resistance. So when T1D. So I'm not sure really what we're referring to. So a little bit more information would be great. And insulin resistance is actually very commonly caused by octreotide and lanreotide. So this is something we have
Oh,
not been paying attention to.
type 1
So
diabetes, Dr. Halfdanarson.
oh, okay. Oh, of course.
Yeah,
I'm so
yeah,
far
I
from
had
being
the
in trouble.
same
Yeah.
moment when I saw.
Yeah, got it. So yeah, so great question. So yeah, so it's we know that octreotide and lanreotide can alter the sensitivity to insulin. And there was a study from the UK in the last year or two that looked at patients who go on octreotide and lanreotide, and about 10 to 15% of them will develop type 2 diabetes.
Mm.
And that's because octreotide and lanreotide reduce the production of insulin by the pancreas. And as for type 1 diabetes, I haven't really seen it, but sometimes the needs for insulin do change over time. So you may have to adjust that.
Okay, thank you for your question. Here's a question from Tom that I bet a lot of people have. Tom says, "Will immunotherapy ever be an option?"
Great question. So, and for the low grade, well differentiated tumors, it's been very disappointing. And so I'm not saying that there are no responses, but the responses to immunotherapy in well differentiated nets are less than 5%.
Hmm.
So that's with the exception of maybe lung nets. There was one study that looked at immunotherapy in lung neuron tumors and found a response rate of 20%, but it was a very small study, only 20 patients in that group. For the high-grade neuroendocrine carcinoma, there's definitely some activity. About 10 to 20% of patients will have a response. In my clinic now, I have two patients with high-grade, widely metastatic neuroendocrine carcinoma who had a complete response to immunotherapy. And even after stopping the immunotherapy, nothing has grown back 2 years later. So every now and again, you sort of hit it out of the park with immunotherapy, and we're trying to figure out who are these patients. Can we find out ahead of time? And the person I saw today has both a number of mutations and then one specific mutation that actually is predictive of immunotherapy response. Then there is another condition called Lynch syndrome, which causes a number of different cancers, including colon cancer and bladder cancer and ovarian cancer, super responsive to immunotherapy. And even in colon cancer, up to like in some studies, up to like 100% of patients respond. A few months or a couple of years ago, I saw a person with Lynch syndrome and a neuroendocrine tumor, and I thought, this is the person who's going to respond to immunotherapy. So I gave him immunotherapy. Nothing happened. And so I think it just goes to show how little we still know about immunotherapy and neuroendocrine tumors. And they will also, to leave on a positive note, we're still early in the phase of immunotherapy. Like I said, we're in second and first and second generation immunotherapy. We're going to see more. This is like when we got our first iPhones. So now we're like iPhone, I don't know, 14 or 15. So we're going to have
Right.
immunotherapy 14 sometime.
Okay, that's a fair point. Uh, Thanks. And by the way, I misnamed that person. That was from Terry. Thanks, Terry.
Mhm.
From Dennis, how reliable are MRIs in diagnosing spine carcinoid metastasis in people with osteoarthritis in the spine?
That's a really interesting question. I
Hmm.
can't give you a number, but I would say that they are pretty good. And but often we would have to combine that with a neuroendocrine tumor PET or somatostatin receptor PET, gallium, copper, dotatate PET. So spine metastases are usually, you can tell them apart from arthritis, and based on the location within the spine and just the appearance on the MRI. But there are benign lesions in the spine. I just saw someone last week who has these really distinct benign spine lesions. I thought were metastases, and they're not. And so tricky to tell, but a good spine radiologist should be able to tell with pretty great certainty.
Got it. Thank you. Appreciate your question, Dennis. From Fred, can a person live with a typical lung net for years without any treatment?
That is probably a yes. So we, and this is so. Like I said, I was giving a talk on lung nets yesterday. So I had reviewed a lot of the lung net the literature because I was giving this to a bunch of lung cancer specialists who treat lung cancer in general and not always in net. And some of the typical nets you can actually observe. And if you look at the net guidelines that are now published, the observation or without therapy is definitely an option for typical lung nets. And this will now, in what some people know here, the NCCN guidelines, this is now also an option in the NCCN guidelines. So yes, there are some people, and I will tell you this. So I have a patient with MEN1, and MEN1 patients get pancreatic neuroendocrine tumors and also get lung neuroendocrine tumors. And she was diagnosed with a lung NET. And the local oncologist was thinking, should I or should I not treat this with surgery? This was 10 years ago. It hasn't changed one bit, and we haven't really treated with much yet. We actually used lanreotide eventually for the pancreatic nets, but you can sometimes watch them for a long time with no change.
Got it. Thank you. Folks, we got about 15 minutes. Gwendolyn joining us from YouTube says, is there a specific percentage of limited healthy liver tissue that takes PRRT off the table?
Yeah, that is such a good question. So it's we don't really know, and it was often said that if you had more than 70 or 80% of your liver replaced with a neuroendocrine tumor, you shouldn't do PRRT. And I know sounds like I'm bragging, keep quoting my own stuff, but we just published on this from Mayo. So this was a study led by my colleague at Mayo in Florida, Dr. Jason Starr, and his team. So we looked at patients with liver tumors, and we looked at a small cohort of patients who had livers extensively replaced by neuroendocrine tumors, and we found that PRT is actually safe. With one caveat, though, if your liver numbers, the bilirubin and the albumin, are really off, then we have to be super careful. And if the bilirubin is really high, we probably should not do it. But just tumor replacement on its own is not a contraindication. We can still proceed with PRT.
Got it. Thanks, Gwendolyn. Jeanne says, I hope I'm pronouncing that correctly. Just signed on. Will histotripsy be available soon? Any predictions about your use of histotripsy? And could we identify what that is exactly? I'm unfamiliar.
Yeah, so histotripsy is a way to destroy tumors with using, I think, like ultrasound waves.
Okay.
So it's going to be one of the options like ablation, stereotactic radiation. So for localized smaller tumors, I think it's probably going to be a valuable option down the road. It's hard to get. There are trials ongoing, so histotripsy will, I think, be added to a fairly long list of regional therapy. Whether it's going to be any better than ablation or I don't know. It just remains to be seen. But it's an exciting option for smaller localized tumors.
Got it. From Rose, what if sandostatin cannot be tolerated? Are there other ways, or is there another way to reduce serotonin levels?
Yeah, so yes. So it's true intolerance to sandostatin or octreotide or lanreotide is actually very uncommon. So like intolerant to the point you can't really give it. I have seen 2 or 3 patients who just could not take it. And so it's real. A lot of people get some side effects, but you can almost always manage the side effects of these drugs. So, but if you're truly intolerant of octreotide or lanreotide, and the serotonin is the issue, we have a great drug for it. We have Cermelo or telotristat that may work to lower the serotonin levels. And then we have PRT, and then we actually have some of the other systemic therapy options. So yes, we can typically find a way to lower the serotonin. And if it's like large liver metastases that can be embolized or radiated, that's also a great way to lower the serotonin. So almost always can we find some method to do it.
Okay, thank you. Sean says, are there trials open for the Sorrento? I'm also unfamiliar with that.
Yes, Sorrento is actually a name of that's actually a name of a trial that is currently open.
Okay.
So the Sorrento study is Sorrento is the name of this phase 3 trial looking at subcutaneous or octreotide given under the skin, self-administered like an insulin pen, and so given every 2 weeks or possibly once a week. And this is just a new delivery method of an old drug. And it's been sort of chemically modified a little bit so it gets really absorbed well, so from under the skin. And in this study, patients will be randomized to either the experimental self-administered subcutaneous octreotide versus either octreotide or lanreotide. That study is going on in the US at least like 6 or 7 or 8 locations. But here's the caveat. you can only be have been you cannot have been on therapy for more than 6 months. So if you just got diagnosed with a low-grade neuroendocrine tumor, you might actually be eligible if we do it within 6 months. It's a very, very important study to do.
Got it. Thank you. From Stephen, what are the distinctions between functional and non-functional carcinoids?
Yeah.
Different.
So excellent question. It's there isn't really a universally agreed upon definition, but what we use, for a lack of a better option, is that a functional tumor is a tumor that produces a hormone or serotonin that results in a syndrome, in symptoms or some tissue damage. A non-functional tumor is a tumor that does not cause symptoms from any hormone production. So you can have tumors that make a lot of hormones, but if the hormone is not causing you any problems, we call it non-functional. But it's still making the hormones, but the hormone is just not causing you any problems. So that's the definition we use right now.
Understood. Thank you. And thanks for your question, Stephen. Time for a few more. Grace says CT shows mixed response after 2 years of octreotide. One intestinal tumor is growing, and others disappeared. Liver metastases have reduced in size. Is it time to move to a new therapy, or to isolate the one tumor that is problematic and deal with that instead?
Yeah, so good question. So, and something we talk about a lot. This would be typically a situation where we would bring the case to tumor board and talk to the surgeons and the radiologist and radiation oncologist. And if, let's say, if you have a mixed response in the liver, and most of the tumors are unchanged or smaller, but one or two or three are growing, it in some patients makes sense to go after them. But the problem is that we don't have good data. I can't tell you how effective it is and how long it's going to last, but we're doing it more and more. And there was a really cool paper a couple of years ago from Toronto, looking at the stereotactic radiation to the liver, delivering very high doses of radiation to small parts of the liver. It's very safe and it's actually very effective, but not used much. So yes, for some patients it makes sense.
Got it. April says, hi, I'm wondering about Mayo, Rochester, and Dr. Thor and other providers traveling to see patients at other geographic locations. Is this true? And if so, what are these locations?
So meaning that if the thing is that the providers traveling to other locations, we don't do that. So Mayo, for example, has 3 locations: Rochester, Minnesota, Phoenix in Arizona, and then Jacksonville in Florida. All 3 sites have neuroendocrine providers, so neuroendocrine experts. So and some other locations have something similar. We have a lot of patients who travel in to see us, but we don't travel out to see patients. And unfortunately, there have been some new restrictions on virtual visits. So we were able to do a lot of like initial virtual visits, but for complex reasons, that is getting much more difficult to do. So now we just have to see patients in person.
Okay. From Steve says, can PRRT be administered after a stent, having a stent fitted to the liver, pancreas, bile duct?
Absolutely, perfectly safe in most patients.
All right, there you go, Steve. Thanks for your question. From Alan, shifting gears a little bit. I'm 4 months into a CAPTEM or CAPTEM chemo for small pancreatic primary and extensive liver mets, showing some responses to the chemo. How many cycles before moving on to other forms of therapy?
Fantastic question. And so we used to give CAPTEM as long as nothing was growing or things were shrinking. Now we're actually starting to limit the CAPTEM to anywhere from 9 to 12 cycles. So 9 to 12 months, essentially.
Okay.
And about 40% will have like a really notable shrinkage. Another 20 or 30% will have some degree of shrinkage, but not just meeting formal criteria for tumor shrinkage. And some of those who have shrinkage can go on for months without any tumor growth and any further therapy. I used to transition from CAPTEM to injections with lanreotide or octreotide after I was done with the CAPTEM. Now I actually just wait. So 9 to 12 months, if there is stability and no growth or shrinkage, stop after 9 to 12 months and just wait and scan every 2 to 3 months.
Okay. Thank you. Now let's switch gears from there. Felicia says, any thoughts on mistletoe therapy along with traditional net treatments?
So no data. So I personally am open to patients trying things like that, but I tell them there are no data. I think, honestly, I think with alternative and complementary therapy, it should be put to the same sort of rigorous standards as other therapy before we can say it works. But as long as it doesn't interfere with treatment, and let's say a patient really wants to try it, I'm open to them doing it. But there are no data on mistletoe and neuron tumors.
Yeah, and Felicia, if I could jump in there as well, I mentioned earlier in the program the shared experiences and stories within the patient community. This is one of those instances where I think that could be valuable talking to someone who has, and specifically, last year we did a patient-centric series, a documentary series, and a couple of our patients did try this, and maybe they can speak to it more from their experience, of course, anecdotal data, as it were. But there's one called Dare to Dream, the Taryn Hillen story. Taryn is awesome, but I know that she that was part of her comprehensive practice. So maybe you could watch that, and she's a public figure, so you could probably reach out to her, and maybe that could help.
And I will just add to that. I wish we had more studies on this. So and we got the questions about that and medical cannabis and
Yeah.
others. I just wish that there was funding to actually properly study these things.
Yep. Understood. Okay, we got just a few minutes left, folks. I'm going to try to get to as many as I can, but there are a lot left. Spoiler alert. Okay.
I'm happy to come back anytime.
And hey, and we're happy to have you, sir. And the numbers keep increasing, so that always is a great sign. It's usually the other way around with other live videos, not lunch with the experts. Reese says, "I'm a low grade two PNET Mets to liver, diagnosed on 421, had two chemoembolizations that year. Still a good bit of tumors left in the tumor, but can you go in and debulk the liver without having the major hemicolectomy?"
Sometimes you can. And this, I think, this is where we really need the tumor board discussion, and you need like an expert surgical oncologist or a hepatobiliary surgeon. So there might be situations, but it's this. Yeah, this is definitely one of those that requires a very thorough, careful evaluation before anyone makes a move.
Got it. Here's a very interesting question that I haven't thought about yet. But Jim says, okay, here's an AI type question. Recently, I read about AI looking at CAT scans. Example, e.g., my good cat results from yesterday showed a few stable sub-centimeter hypodensities within the liver. How common is that? How common do you expect it to be? What are your thoughts?
So we see a lot of if we just address the liver first, we see a lot of things in the liver that are not necessarily related to cancer, and especially if you switch modalities, or even if you switch scanners and contrast timing. So that seeing something new in the liver from one scan to the next doesn't have to be tumor growth, and oftentimes we just follow with another scan. As for the AI question, I'm not the radiologist, but I can tell you there is an explosion of AI research in radiology. It's not going to replace radiologists, but it's, I think, going to make our interpretation much more precise. And I think AI, if I had to guess, I think within 5 to 10 years, AI is going to be pretty routine in radiology.
Got it. Thank you. Michael says, isn't there a version of PRT that is delivered directly to the liver in the fashion of the like a radioembolization procedure?
Absolutely. So that's called intraarterial PRT. So not a whole lot of data. So University of California in San Francisco had a study on this, or they at least were leading it, and they did report it, and the results were not that promising. So I think the enthusiasm for that has gone down quite a bit. But I'm not saying we shouldn't do it. There are some patients who have had really good response, but I'm not sure what the future is of that, especially with alpha particles coming.
Got it. Well, folks, that is our hour today. I just want to thank you, Dr. Halfdanarson, for being back on the show. It's always a pleasure, and I think this might be our highest attended show this year. So that's
Wow. No, it's a pleasure, and thank you all for taking time to call in. outstanding question. I wish I could stay here for another hour or two and address all of them. But
We
like I
could
said, I'm
fill it.
happy to come back.
Yeah, we could fill it. Folks, know that we had, like I said, a lot of numbers today, so we didn't get to all your questions. Like I said, we rarely do. But I really encourage you to reach out to us at carcinoid.org. You can message us here on Facebook or wherever you are. Remember that we have now partnered with LACNES, and we have that support line going so that we can get you the answers to your question. We'll be back next month with the show, but that's something that you can leverage and utilize in the meantime, and I really encourage you to do that. And I appreciate you all being here as always. I hope that this program helped answer some of your questions, and please reach out to us if you have any follow-up questions. Thanks again to our presenting sponsor, Ipsen Biopharmaceuticals. We couldn't do the show without them. And finally, my name is Rain Bennett. I have been your host. Thank you for watching. Please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everyone. Bye-bye
Yeah.
now.